Great. Perfect. Alrighty. Great. So if you're just joining us, this is the Filipinx Health Initiative SF COVID-19 virtual series. And this is our first session, week 1. And we have a really awesome speaker planned for tonight. So we can go ahead and get started. I will pass it off to Jaya, who will be doing our grounding.
Is there the next slide?
Please.
Hello, I'm Jaya. Before we do our grounding, we'd like to start with remembering our brothers and sisters in the Black community, Manuel Ellis, George Floyd, Breonna Taylor, Ahmaud Arbery, Sean Reed, Tony McDade, David McCarthy, and countless more whose lives have been taken at the hands of police brutality, with a few moments of silence. You all. Black Lives Matter, no justice, no peace. And now if we can all place our hands on our stomachs and take a deep breath in, feeling the air fill your body, and exhaling out, feeling your muscles release, releasing tension, and repeating this once more, being mindful of the body and any places you may be feeling heavy, and acknowledging those feelings, recognizing that there is a lot going on and to be present in this moment. And repeat. Thank you all for participating. If you need to repeat this to be more present, feel free. It's very heavy times right now and it's completely reasonable. And to also keep in mind our mental health during this time. I'll pass it off to Cami and Tanya.
Great. Thank you so much, Jaya, for that grounding and for helping us to remember to stay present amidst all the things that are going on in the world. I really appreciate it. Thank you. And going off of what Jaya had just said, not only as an organization, as the Filipinx Health Initiative, but also the individuals in our collective, we understand that our liberation, the liberation of the Filipinx community, is inextricably tied to the liberation of our Black and Indigenous comrades, and that our conversation today is just one step towards recognizing our relationship. And so I thank you all again for being present here today. Next slide, please. So here we linked some resources, some ways to support. This COVID-19 virtual series is a part of the National Alliance for Filipino Concerns Bayanihan response to COVID-19. So we have linked there every Sunday. We have a Bayanihan concert that y'all can tune into, excuse me. And we also have the link to the Bayanihan PayPal. In addition, we also have some organizations linked there. The Black Visions Collective, which seeks to expand the power of Black peoples across the Twin Cities metro area and Minnesota. We have a link there, as well as a couple of Black-led LGBTQ organizations. We'll also be having this slide at the end of our presentation today. And our questions person, Erin, has linked that in the chat as well. Next slide, please. So a little background on who we are. The Filipinx Health Initiative, SF, is a collective of individuals whose purpose is to bridge health and wellness resources for and by the San Francisco Bay Area Filipinx community. As such, we are also an affiliate of the National Alliance for Filipino Concerns, which is NAFCON. And we have several points of unity, which includes empowering the Filipinx communities in the San Francisco Bay Area, preserving and celebrating Filipinx culture and history and heritage, promoting the rights, health, and well-being of Filipinx, and advocacy for Filipinx communities in the US and in the Philippines. Next slide, please. And here is our speaker for today. But before we get started, I just want to remind everyone to have their mics muted. We will have a question and answer portion at the end of our presentation today. So any questions can be directed to Erin, who's our questions person. Her name is questions-Erin. So please feel free to send her your questions. Also send them in the chat. Also shout out to all the folks who have supported us through logistics. We have Janelle typing our closed captions, Kristan, who will be facilitating with me, Jaya for the grounding, Tanya for the music, Elena for security, and Mary Beth for sharing, for doing screen share today. So shout out to everybody for making this happen. So let's get into it. Our speaker today is Dr. Ryan Huerto. Dr. Huerto is a family medicine physician and research fellow. Oops, my bad. In the National Clinician School program at the University of Michigan. He is passionate about workforce diversity, disease prevention, and, sorry, captions are blocking, and health justice. Ryan, the floor is all yours.
Awesome. Thank you so much for that introduction. And thank you so much for starting with that moment of silence. I think that's 100% necessary right now with everything going on in the world. How's my audio? Can you hear me okay? Yeah, awesome. And I just want to start by thanking everyone for being here. You could be anywhere, especially with so much going on in the world. I'm so glad to see that there's a diverse group of folks from public health, nursing, I saw clinical research, OB-GYN. So thank you for being here and especially for sharing the space with me. So I'm going to go ahead and dive right in by sharing my screen. Okay. And this is going to be an interactive talk. I'm hoping to get through it in half an hour, which will leave us about 15 minutes for Q&A. And I'm really hoping we can finish early to have that discussion about racism in our community in ways that we're currently addressing it. So this is my talk on Filipinx health disparities, the importance of data disaggregation, and CBPR, which is short for community-based participatory research. And let's go ahead and just dive right in. So I think a lot of you are still in undergrad. Some of you are in grad school. Some of you have graduated. I always think it's helpful for me to kind of talk a little bit about my background and journey, because sometimes for some of you making those decisions, if you're in like a fork in the road, it can be helpful to hear other people's journeys. So I started my college education at UCLA, where I studied psychobiology. And I was pre-med throughout that time. And towards the end, I was still pre-med, but I was feeling like pretty burnt out on the whole pre-med grind. If any of you are pre-med, you can probably relate. So instead of applying to med school right away, I decided that I want to do something else to kind of reflect on my long-term trajectory. And I wanted to do something that would involve service. So I actually became a high school science teacher here in LA. I know y'all are mostly in the Bay. And I taught physics, chemistry, and biology. And I also got a master's in arts, in education, policy, and administration. So from that point, I was already thinking very structurally in terms of like, what are the structures, what are the policies that kind of determine people's success in their health and their educational attainment. And after 3 years of teaching, I decided that I still wanted to pursue my dream of medicine. So I was very lucky to matriculate to UC San Diego in their PRIME program, which is a special program that focuses on health equity in underserved medicine. And during that time, I was able to do a dual degree at Harvard, where I earned a MPH, Master's of Public Health, with a focus on health and social behavior. And that's just, it kind of really broadened my perspective, just thinking even more like upstream, what are the social determinants of health? And that was in like 2014 when Black Lives Matter became a national movement. So that really was such a formative experience for me in terms of like how I wanted to serve and how I wanted to try to align my clinical practice and my research and my public health practice with everything, all the injustices that we're seeing and which are really, really highlighted today at this moment. So for residency, I went to UC San Francisco, shout out to the Bay Area. So I did family medicine. And if any of you are familiar with the general, we serve a pretty underserved population in terms of the Bay Area. So I was lucky to train in that program. And then after that, my current role, I'm a postdoctoral fellow studying health services research, where we already mentioned some of my research interests. Workforce diversity, chronic non-communicable disease management, pipeline programs, as well as other things like youth perspectives on HIV, PrEP, patient-provider concordance, a number of things which I can talk about after this talk. So the outline, I'll be starting by talking about Filipino health disparities specifically related to coronavirus. And then I'll move on to the importance of data disaggregation. I'm gonna relate that directly to coronavirus. And then I wanna see what questions that y'all have. I know some of you submitted questions before the talk on CBPR. I'm gonna do my best to answer those questions. I have been involved with multiple CBPR projects. And then I'm really hoping that I'll be quiet early enough or soon enough that like we can really talk about the most important, in my opinion, the most important issue right now is how do we combat anti-Black racism in our community and even outside of our community. So I'm gonna start off with two definitions. So health disparity, that is a higher burden of injury, illness, disability, or mortality experienced by one group relative to another. Now, what we're striving for, whether you're a nurse, a physician, a public health worker, a social worker, a community worker, an activist, is really health equity. So what is that? That's the absence of avoidable, unfair, or remediable health differences among groups of people. And in my mind, I always think of preventing disease prevention, I should say, as a form of social justice in healthcare and public health. And that's been the case like throughout my training. And that's kind of the lens that I try to look at these things from. So I got a question for y'all, and I want you to go ahead and type in the box. Describe what you see in this image. You may have seen it before. And then I'll go ahead and read some of the comments. And I'm a former teacher, so I can wait a long time. I don't mind moments of silence. I love it. So I see liberation for one person must be liberation for all. Sounds like someone's been reading about how we get free and intersectionality there. Equity isn't the end. I love it. Yeah. Describing liberation, the quote unquote wall is the structures that perpetuate the inequity we see in the other two pics. Wow, you should really be giving this talk right now, or y'all should be giving this talk. First photo should technically solve the problem as everyone was given the same solution. Gotta move towards liberation, not just equity. I love it. Okay. And then you also hear the term equality. Oh, I mean, that's the first one, what am I saying? So I think that's kind of, in terms of the consciousness of folks, people have kind of moved beyond the concept of equality and equity, understanding that you can't treat everybody the same and expect a good outcome for everyone. Obviously, it's more complicated than this cartoon, but I think this is a really important way of having a baseline understanding. So I'm gonna ask you a follow-up question. Now that we kind of have that baseline understanding and we're all on the same page, can y'all give me like one example of something in real life that could have an impact on your health, where you might have these three scenarios? And I'll give you a moment to think about that. So in other words, give me a real life example of this related to health. Awesome. So I have women's reproductive health, the air quality of where I am raised. I could relate to that one. I grew up next to like an oil refinery, so I could definitely relate to that. Pregnancy and mortality rates amongst different races. Okay, great. So there's a lot of like women's health, OB-GYN themes. So I see that there's a strong passion for that topic here. Environmental racism, where Black and brown communities live in places that don't have access to healthy food. Awesome. And the very next person said right there, food deserts. You're kind of like on the same wavelength, which is great. Redlining and education access, different zip codes with the same city. Within the same city, health literacy. I think with the zip codes comment, maybe that's commenting on the fact that like being born in certain zip codes can often like be a strong predictor of someone's health outcomes. And then health literacy. Oh, okay, Anthony, my friend, you are reading my mind, because that's going to be on a future slide. So that's awesome. I'm going to go ahead and keep going. So the question that I have now is, how do structural racism and capitalism increase COVID-19 risk? And when I say COVID-19 risk, I'm not talking necessarily about dying from coronavirus. I'm talking about contracting or catching coronavirus in terms of just getting the infection. And I kind of, as a hint, as a guide, I've given several examples, but I want y'all to try to break it down further if you can. So in terms of these different facets of life, from employment, housing, neighborhood, education, income, healthcare, and whatever else you can think of, can you give me an example of how structural racism and capitalism makes it that someone may be at higher risk of coronavirus infection? I like it. So the first one's language literacy. Coronavirus information is not being disseminated in languages other than English. Absolutely. And there's an example later on where a lot of times the advocacy, the activism has to come from the community in terms of translating that information and making it accessible to folks in the community. So someone says, Black and brown folks work in essential services. Absolutely. So I would describe that as they're disproportionately represented in essential worker roles in which people are more exposed to many other people and possibly the virus. Testing's been quartered off to only certain zip codes. And we knew very early on, right? There was stories about, I don't know if y'all remember, but there was countless NBA players, those famous people who were like very wealthy, affluent, had a lot of influence, who were accessing the valuable limited tests. And even at its peak, and we don't know if it's gonna come back, if it's gonna surge, there hasn't, in my opinion, been a strong effort to prioritize folks who are at higher risk of serious illness in terms of testing. So there's a lot, wow, a lot of responses. Working class can often be essential workers. Okay, good. High representation of Filipino women in healthcare and caregiving roles. Foreign export policies that facilitate this. Awesome. Like I said, y'all could be giving this talk. Labor export policy, not providing enough PPE. Okay, let's see if there's any of them that we didn't break down. So someone already mentioned air pollution. So I would count that as under neighborhood. For housing, something that I could add, someone mentioned like redlining, if I'm not mistaken, and gentrification. So often, sometimes like living in more crowded living conditions, and if you have those discriminatory housing policies, that can influence that. Education, language can go hand in hand. Income and healthcare, there you go, that's the one I was waiting for. Health insurance, accessibility, right? Like, are people gonna be able to afford all their medical bills or even access the care they need if they have the insurance or not? Politicians not issuing a stay-at-home order. Excellent, excellent, excellent. And it's really ironic, and I tweet a lot, maybe too much, but the kind of, I would say, hypocrisy in terms of treating the current protests, which are righteous protests, as more of a safety concern in terms of implementing a forced curfew versus like when coronavirus was like, when there was more infections and Black and brown folks were dying disproportionately, it was like, all right, states or cities, do whatever you want, right? So it's important to kind of pay attention to those things, right? As they kind of show where people's priorities are. All right, so phenomenal participation. Let's keep going. What are some diseases that increase risk of death due to coronavirus or COVID-19? For you clinicians, I might want y'all to hold off on this one, but try to think of like 4 or 5 things that you might have heard it in the news that folks who are dying at higher rates tend to have had these conditions prior to contracting coronavirus. All right, someone's crushing it. So chronic diseases, type 2 diabetes, high blood pressure, heart disease. What's the term? A plant? It's like when you have someone in the audience who knows all the answers. Asthma. Okay, great. Awesome. So I'm gonna go ahead. Let's see if these aren't all the risk factors, but these are just some of the main ones that I wanted to highlight. Diabetes, which y'all got. Heart disease, Someone said cardiovascular disease, so you got that one too. Lung disease, someone said asthma. So there's another form of lung disease that's very common, which is COPD, which is from chronic smoking of cigarettes. So that would also fall under lung disease. Obesity, so I didn't see anyone mention obesity. And then a weakened immune system, okay? And we don't 100% know in healthcare and science like why it is that these things make you more susceptible to coronavirus. I mean, I could definitely kind of try to reason it out, but there's still so little that we really know about the virus that it's going to be a while for us to completely understand the relationships between these things, okay? But one thing I will say is that it attacks the lungs, and like your heart and your lungs are related. Your heart pumps your blood, which gets oxygenated. So if you imagine like someone's lungs are getting filled with fluid and inflammation, and it's not getting enough oxygen into your blood, that puts a lot of stress on your heart. And diabetes, we see folks become immunocompromised. They get end stage kidney disease. Their kidneys start to fail when they have really, really bad diabetes. Lung disease, I mean, that one's obvious. Obesity, I'm not 100% sure, but I know that when folks get really sick, they have to get intubated, meaning a tube goes down their airway and the machine breathes for them. And oftentimes in medicine, and even in like routine surgeries, it's harder for people to start breathing on their own again when they're very overweight. And the weakened immune system, obviously they're fighting an infection. So that one makes sense too. If you have any questions, feel free to type in the chat box if anything I'm saying is not making sense. So this might feel like a complete 180-degree turn or like a tangent. Why am I talking about the model minority myth? What does that have to do with any of this coronavirus and health? But I want you to think, I'm assuming all of you are familiar with the model minority myth. I mean, most of you are in California. You're mostly considered as Asian, depending on the person. It's mostly applied to what, right? Education, maybe income, Asians being politically docile, not rocking the boat, you know, kind of just like going along. But without, oh, someone already typed it, thank you. So we are assumed to be a healthy, quote unquote, minority with no health issues. Thank you so, so much. Okay, that's exactly what I was looking for. And the reason why I talk about the model minority myth so much is that it's more than just someone saying like, oh, you're good at math. It's actually pretty dangerous. And I actually wrote an op-ed, I co-authored it with some folks about why it's harmful potentially to the Asian American community. And we know for a fact, and outside of healthcare, sociology, critical race theory, like they've been studying this for ever since the model minority myth came about. And some of the things that I want to highlight that it does is it pits us against other minority groups, right? And when I say that, I mean like our non-Black Filipinx brothers and sisters and like our non-Latinx Filipinx brothers and sisters, right? It's kind of like saying, well, if Asians are doing better, then everyone else is doing worse because it's their fault, right? That's what the myth does, right? And a lot of folks in the Asian American community, we kind of feed into that. And that creates a division between us and other minority groups. And we have to really acknowledge and interrogate our own privilege in terms of like the policies that allow us to become more successful in those instances where we are more successful, okay? So the bottom line, I think, is that we need to be actively deconstruct this, because if we were to become anti-racist, we need to deconstruct a myth that's being used to perpetuate racism in our community and that's keeping us divided. So I hope that makes sense. Keep that in mind for these next slides, okay? So this is a very important study that came out of California. It's called the CHIS dataset, C-H-I-S, and it's called Health Conditions, Outcomes, and Service Access Among Filipino, Vietnamese, Chinese, Japanese, and Korean Adults in California, 2011 to 2017. Now, this is a super duper 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 important study if you're interested in Filipinx health disparities, because it's one of the few that actually looks at our outcomes in terms of health separately from these other groups, right? So if we think of the model minority myth, that literally, you can see that in terms of health. And the way that that happens, I'll go to the next slide. Asian Americans typically rank as healthier than the general US population, but a new study shows that this is only true when data is looked at collectively. And another way of saying that is when data is aggregated. Okay, so when Filipinx are combined with other Asian groups, and oftentimes even with Pacific Islanders, okay? And what this study showed, which is really important, is that Filipinx appeared to be in the worst health of all Asian subgroups in the study, okay? Let me repeat that. Filipinx appeared to be in the worst health of all Asian subgroups in the study. So if you think about it, if the model minority myth is applied to us, and there's this perception that Asian Americans are doing better in terms of health, then what type of a disservice does that do to our community, right? And I'll give you some specific examples related to coronavirus. Compared to Asians overall, Filipinx were found to have a higher prevalence, and this is in California. Let me emphasize, this is one of the limitations, this is Filipinx in California. Higher prevalence of high blood pressure, asthma, and heart disease, okay? And then in addition to this, several other studies show that Filipinx have high rates of diabetes, right? And you probably know a lot of this already, especially with the diabetes, right? Because there's folks in our community who have spoken up about this, right? Based on the limited data that we do have, right? When we're seeing that much of a pattern with limited data, it's hard to ignore, right? And we don't know how Filipinx are doing in all other states if they're not separating the data, right? And the data is only half the battle. And what I mean by that is, even if we had all the data, right, it doesn't solve the solution. There needs to be action. There needs to be resources allocated towards solving those issues, all right? And I just want to emphasize that, like, we saw this already, right? High blood pressure, lung disease, heart disease, diabetes. These were the risk factors that we pointed out in terms of what makes people more likely to die of coronavirus, right? It's like everything that our community has a high prevalence of in terms of disease is making us more susceptible to serious coronavirus infection. And what I want to highlight, that what I don't want you to take away from this is that Filipinx, they don't exercise, they don't eat right, they smoke a lot of cigarettes. You got to think more critically than that. And that is the reason why I wanted to show you these factors: employment, housing, neighborhood effects, education effects, language effects. And these are only the ones that fit on one slide, right? And the thing is, everything is connected. So the high proportion of Filipinx nurses in the US, they're here because of the history of colonialism, right? And I'm gonna share some resources, but this is a well-documented fact, right? That when the US needed more nurses, they propped up schools in the Philippines, nursing schools, which created the supply of overseas workers, which to this day, we are still dependent on many immigrant Filipinx nurses to take care of the US population. And it's pretty absurd when you think about when coronavirus happened, what happened? We had to ban immigration, okay? I get it, that slows infection, but like the selective immigration, you have to pay close attention to where's the immigration being banned from? Because some of the studies showed that early infections came from Europe, right? So you got to be really careful when public health measures, when things that are going on, when there's chaos, that gets used in order to oppress Black and brown folks, right? And folks with colonial relationships with the US, right? So let's keep going. I want to emphasize that we're not alone in this. So this is a physician in LA from the Pacific Islander community. And I want to highlight a really, really devastating number. In LA County, it was showed the Pacific Islanders had a 12-fold increase of death due to coronavirus compared to their white counterparts, okay? 12 times more likely. And the only way that that's possible to even estimate that is to have the data, right? And the sad part for Filipinx nurses and Filipinx essential workers, we don't have that data. So we don't even know, we're relying on individual stories, journalists, which is great, they're doing a great job, but we shouldn't have to look through every newspaper article and count one by one and say like, well, this person has a Spanish last name, are they Filipino, are they Latin, you know, like, no, we should build structures in order to facilitate this. And I'm oversimplifying it, of course, because if you could imagine that this is a highly politicized issue, right? This is like highly coveted information. And even in what we're seeing with coronavirus, the early race data, if you paid attention to the news, it was a ton of resistance, even for other minority groups, right? Like for Black and brown folks, right? Like folks had to advocate for that, right? So let that sink in. And I want to highlight in the Pacific Islander community, they're doing some really cool stuff. They started translating information on coronavirus. They started partnering with their church community in order to create spaces for folks to safely quarantine from other folks who weren't believed to have coronavirus. And they're also continuing to advocate for this disaggregated information, because once you know that number 12-fold, you're much more likely to act and allocate resources to solving it, right? Next, so the virus has been twice as deadly, sometimes even more, 3 times as deadly for Black folks compared to whites and for Latinx folks. And this is specifically just New York City. But I know that in the Bay Area, there's been high rates of Black and brown folks dying due to coronavirus, right? I don't know how much it's in the news, but in every state, you're seeing these disparities in terms of race and ethnicity and coronavirus death, okay? So we're not alone is the part that I'm trying to emphasize. And then the last group I wanted to mention is that the Native American, the indigenous community, the Navajo Nation. And there was some really kind of, you just have to stop in your tracks and really stop and really reflect on it. There was one article that said certain communities didn't have clean drinking water to even wash their hands with, right? Think of how important it is to wash your hands when you're in a pandemic and there's a virus going around through the entire world and you don't have clean drinking water to wash your hands, right? And there's also high rates of chronic disease in these communities as well. The Black community, the Latinx community, the indigenous, Native American community, there's high rates of those things as well. High blood pressure, heart disease, diabetes, lung disease, obesity, right? There's a theme here, right? I'm trying to show that we can't just attribute all of this to individual behavior and say that all these people live really unhealthy lifestyles. No, this is structural in nature, right? Because what we're seeing is these massive disparities where there was already a disparity before, and all these things we're describing, like diabetes, if I live in a food desert and I have to eat processed foods, I'm probably gonna get diabetes and hypertension, right? If I don't have good lighting in my neighborhood, if the sidewalk's all messed up, it's gonna be hard to exercise outdoors, right? If I live next to that, someone said they lived like with a lot of air pollution, I can relate to that. Well, what happens with your chronic lung disease? You don't even have to smoke to get chronic lung disease if you live right next to a factory that's producing a lot of air pollution, right? So one of the takeaways I want you to have from this is that once we get I'm optimistic, I'm cautiously optimistic that in our lifetimes that we'll be able to get disaggregate data on Asian American Pacific Islander communities. But what I'm saying is that the solution isn't to take resources from one group and to give it to us. No, I'm thinking that all these groups that are disproportionately being affected, we need to come together and work on structural solutions, right? We're much more stronger when we're working together than when we're trying to fight each other, right? That's the whole point of the model minority myth, is that it divides us. And unfortunately, a lot of folks in our community perpetuate that division. They deepen that division by buying into it, right? The notion that being white adjacent, or that by being on someone's good side that you're safe, right? But we've seen with coronavirus, we've seen spikes in racism against Asian Americans, right? And that's why so many of us in our Asian American community are talking about this during coronavirus, and even more so now with so much police brutality in the news, right? All right, so let's keep going. I want to highlight there was a study in early May out of San Francisco that showed over half of the deaths in San Francisco were of Asian Americans, right? Now, I'll say this with a grain of salt, because San Francisco, the Bay Area, has done a really good job of fighting coronavirus, right? Out of all the states, San Francisco, or all the cities, was one of the most strict in terms of trying to fight coronavirus. And because of that, you see there's fewer deaths. That's science, right? That's public health. Like, that just makes sense, right? But unfortunately, over half of those deaths are Asian Americans, and much less, even though California has a lot of Asians, we're not more than 50%, right? That's a big number. And let me ask you another question, I think critically, because I don't have the answer. Out of that 50 something or greater than 50%, what was the breakdown, right? How many of them were Filipinx? How many of them were nurses? How many of them were essential workers? How many of them were Southeast Asians? How many of them were Pacific Islanders, right? So these are questions that when you become researchers, when you become clinicians, when you go into public health, social work, a lot of it's on us, right? We have to advocate for these things, for the data, and then the action that follows it. In whatever way, shape, or form, like, you don't have to be doing work in the community through the academy. It doesn't have to be through any of those roles. There's plenty of folks who are community health workers, and they help in sometimes, like, even more important ways, right? That we can't connect with communities and build that trust and that partnership as readily, because there's folks who are always in the community, right? Okay, so I know that's really heavy. Oh yeah.
Before you move on, we have a
Yeah.
question in the chat.
Sure.
Do you have a citation that we can send out later from
Yeah,
that study?
I'll definitely send some links.
Okay.
I'll send some links to the organizers, and I appreciate y'all in advance for sending it out. So I want to highlight some wonderful work. Speaking of folks in the community and activists, I want to shout out the FIRM organization. I don't know if y'all are familiar with the FIRM. I hope I get this right, but they're a transnational feminist organization that is against all forms of oppression. And they did something I'm so blown away by. So they created this thing called kalungan.net. That's actually the URL, kalungan.net. And it's a tribute to Filipinx folks who have passed away from coronavirus. And remember when I told you that, like, it's a ton of work? You got to look at the newspapers and link it up. Well, I'll tell you what, I spoke to one of them and they said, we verified through 2 sources for each of these individuals that they were in fact Filipino, right? And once we had 2 sources saying that, then we added them to the list. So they've actually done this for every single one of those folks that they've been able to find through news reports, and they've humanized them. They're more than a statistic. They've told the story of each of these individuals. So I highly, highly recommend you visit this site and kind of pay tribute to these folks, okay? And the next slide, this is kind of one of the pictures that they had on their website. And then that's the name of the organization at the top. So really, just like y'all, really, really cool, really awesome, really woke. And I mean that in, like, the good sense, not like when people use it sarcastically. Group of women, which I see y'all following those footsteps, which is awesome, because I think you're going to make amazing advocates for your community. Some resources, and I can send some links out to this. There's an American Sickness that talks about how the business aspect of healthcare, which has only gotten worse over time, is harming people. The middle one is Medical Apartheid by Harriet Washington. Every single one of you needs to read this book, okay? If there was one book I had to recommend in terms of understanding the atrocities of these institutions in medicine and public health and science, you gotta read this book. It's so well researched. It's a really hard read. You're not gonna, I had a hard time reading it all the way through because it's really heavy stuff. but really sit with it, engage with it, and kind of like reflect on like our relative privilege when you read these stories. And last but not least, there's Empire of Care by Catherine Choi. She is, I think she's at Berkeley, possibly, but she's done a ton of scholarly work on understanding the relationship that I described in terms of colonialism and the Filipinx nursing workforce that we see today. This is the link or the front cover, I don't know what I would call it, but the op-ed I wrote on the model minority myth. I'll send a link to this. I go into way more depth on why I think the myth is harmful. Shout out to Hafifa and Rosian for co-authoring that with me. And this is actually published in the Gidra, which is a radical Asian American newspaper. I think there's actually overlap between the Gidra, which was founded at UCLA, and SF State. And I'm happy to go over. I know we're getting to the hour mark, but I've got nowhere to be. So if y'all want to stay, I'll stay longer. I'm happy to. There is an overlap between the work that was done at SF State in establishing ethnic studies. What is the organization? Third World Liberation Front, I believe is the acronym. Shout out to SF State, man. Y'all are amazing. Like, y'all are part of that legacy. So the Gidra, they saw what happened at SF State, and subsequently they formed this newspaper, which they brought it back recently, and they talked about issues like such as this that impact our community. This is an op-ed that I co-authored, and it was actually just published yesterday. It's titled, "Doctors Can't Treat COVID-19 Effectively Without Recognizing the Social Justice Aspects of Health." It was partially in response to an article written by another physician in the Wall Street Journal that was saying, medical students or physicians are unprepared. They need to focus on preparing for a pandemic and not injustices. So it's basically saying you have to focus on, I don't know if you're familiar with this term, but something called the biomedical model, which doesn't account for like everything else, like where people live, where they work, where they play, right? Could you imagine thinking that coronavirus was only due to everything else besides those things, and that healthcare providers and allied health professionals, that we're not supposed to care about those issues when those things in fact are making up a majority of our risk factor for disease, and when they're linked to things such as structural racism and capitalism and patriarchy, right? So I have a feeling I'm preaching to the choir, but I think it's important to at least acknowledge that. All right, so I think this is the part where we're going to transition to the Q&A. I know there was some questions for the CBPR portion, but I'm going to go ahead and stop sharing my screen.
Thank you so much, Ryan. Really appreciate you providing all that information. It's super helpful and super relevant. So I'm going to give everyone time to think of questions, and they can type it in the chat box. In the meantime, I will read off some questions that were submitted during registration. So Ryan, the first question that I have is, what are ways that researchers can get the community involved and engaged in community-based health research?
Can I, out of curiosity, I know there's a few kind of experts here, like Katrina, who's about to be a family planning fellow, and Anthony,